Okay, all right.
If you're not using the part-time normally,
Okay, good.
Good morning, everybody. Go ahead and get started. Great. Thank you for being here. We have just celebrations from last time. We have the CPC or CCU, aka not sure the verbiage, but I think it's more CCU, cardiac care unit. Right?
no,
Oh, the CCU is the inauguration. Was just a little ceremony we had. So those rooms are open now, and we're trying to do some high-risk patients after PCI, TAVR, and Watchman up to CCU. We also started out with doing our Watchmans. We've done so far a total of 6 Watchmen, 2 days, and we had several scheduled for yesterday, but somehow or another it didn't work out. But that would be coming up. So we have several in pipeline, and that's going well. And the EP, obviously, that's another major breakthrough. We did our first ablation of both monitored first ablation. So, and that's obviously very robust now, and it's already quite busy. So just 3 major things that happened since we last met. Right, and then obviously we want to welcome you. Just Switcha has really been a great addition, and Adrian's been already you're doing great job with the heart failure patients. So welcome you. Right, go ahead and get started. Barry.
Morning. Thank you, and thank you for the time. What I'd like to do this morning is kind of give you an idea of what we are focusing on as a system, and then where we are as we're expected to our performance. What you see in front of you is our annual goals for the system. We like to take a balanced approach. So we have 7 different pillars that span from quality all the way to innovation. And you can see these in the slide deck what the individual goals are as well. The color indicates where we are from a performance perspective. If we look at quality, we are focusing on our serious safety events. These are adverse events that happen while the patient is admitted in the hospital, either pressure injury, hospital-acquired condition, or a fall. We are performing very well at that. One of the reasons that we focus on that number is it's very tightly correlated with our publicly reported scores around leapfrog and star ratings. So that is the leading indicator for that. So we'll focus there. Also, our leapfrog scores, we are focused to get a B at both of our campuses. We now have published results of an A in Billerica and a C here in Carrollton. Those lag quite a bit in data. So right now they're looking at 2021 to 23. So we're just focusing. That's why we kind of have a serious safety event as well. And then finally, and really very important to this group is looking at targeted readmissions around COPD and CHF for this year as well. That again is very tight, very tightly correlated to our star rating. If we move into service, we're all green there. This is the first time within, I can remember, within the first quarter of the fiscal year that we're actually performing at expectations for service. We did move our target for inpatient from likelihood to recommend to just a straight rate to hospital. And we're very positive there. People, again, very strong performance within our recent engagement survey, and then also turnaround time for the hiring process. We are focusing on new hire turnover. It's above the 30% right now where we need to kind of focus. And why that's important, one is the stability and sort of the ability to create a team, but also the cost to replace that individual. Where we're going to need your help as we move into efficiency, and this isn't new to this group, as we've looked at observation length of stay for years within the chest pain committee. Yeah. All right. Now I'm way too loud. So this is an area of focus for us. We continue to look at ways that we can more efficiently move the patient through the entire healthcare process. We determined we can't create capacity fast enough to meet the need of the community. And coming out of COVID, we had a very significant opportunity within an aggressive length stay reduction. So we are looking on the acute side, the expected versus the actual. We're a little behind in Carrollton, performing very well in Billerica. And I think you all have the biggest impact for us as we look at the length of stay. for observation patients. If you look at the highest percentage of patients that are in the observation status, they're chest pain. So as we look at, you all may not be consulted on them all or have interaction with them, but how do we work with the hospitalist to work through that algorithm to ensure that we're working up these patients as fast as possible and we're getting them to the answer that they need, and if they need you all, that they're there as well. So that's going to be a significant focus, and we do that through the chest pain committee as well. And then the final goal there, we're looking at reducing the number of holds within the emergency department, just as a visual representation of our improvement on the flow of patients to the system. We have seen a small degradation within our operating margin for this year. Historically, we run at around 7%. That's well above the national average. We're currently at 3.1 or 3.7. So we're below our target. So we're looking at ways to more effectively reduce costs in the organization, but more importantly, just ensure that we're allocating resources where they're needed and getting the return for those as well. So I would not anticipate any significant issues there, but just looking at that measure as we move forward. We continue to look for opportunities with cost savings and then the Higgins tax credit. And then the final two are all green, and mostly from this group. We've seen significant growth within vascular surgery, all the things going through the procedural areas. So thank you all for your hard work as we look at bringing on new programs and growing and access for our community as well. And finally, on our innovation pillar, we have a significant focus on how we can implement AI to ensure that we're effectively working with our workforce and eliminating manual processes there. But we have over 8 or 9 different projects within implementation status that have something to do with artificial intelligence to help more efficiently and effectively care for our patients. So that's just a quick overview. Each month we'll be able to give this to you all in written form, just so you can continue to see where we progress. And why it's important, these are how we prioritize the interventions and things that we do within the operational and clinical units that you all engage with. So you should be able to go to a unit and determine where they are within their anticipated impact of each of these goals. It gives us clarity and the ability to cascade and ensure that we're all pulling in the same direction. Any questions?
Who's got the clicker? Okay.
Okay, just have one question. I think on the financial part, one time we talked about the cost per procedure or per, just to see where we lie. And I don't know if there's been any development.
We are very close, working with our finance colleagues to be able to roll out the cost accounting system, which is necessary for that. So within the next 3 or 4 months, be able to see that. What we want to ensure is that the integrity of the data is very strong, so that anything that we're trying to correlate to any changes, that we're able to see that. One thing we are going to do, once we do an appropriate number of cases, both on TAVR and Watchman, we'll bring back the vendors and ensure that we're meeting national benchmarks in those areas as well. For all the folks online, I'm not saying anything that's very important. So don't worry, you didn't miss anything. It's all administration talk.
And I'm up with more administration talk. So hello, everyone. I'm Clint Hoffman, EVP of Tanner Medical Group, and also, as of April this year, Chief Strategy Officer of Tanner Health. Wanted to give a quick update on where we're at in a strategic planning initiative. And so we've launched into a strategic planning project, and I'll talk a little bit about the timelines and kind of the steps that we've gone through. But to underscore the importance of why we're pursuing kind of a very intentional strategic plan right now, we, as Eric had kind of alluded to, are facing some unprecedented kind of environmental constraints on Tanner as a health system. I think everyone's aware that, a big part of the government shutdown was ACA subsidy expansion. And in the state of Georgia, because we did not expand Medicaid, there is a large proportion of our population that utilizes ACA exchange plans, and that represents a pretty significant element of our business. So looking at the kind of landscape and where healthcare, and specifically healthcare providers, are kind of falling into that, from a financial perspective, there is a lot of headwinds that we're going to be facing. So ACA, it's going to reduce our commercial patient population. CMS is also pushing a lot of regulatory changes in how we're paid. So beginning January 1 of 2026, some of the drug companies are going to start requiring for us to participate in 340B that we submit for, we pay the full price and then request a claim or a reimbursement amount back from the drug company on 10 specific drugs. That's going to change our process. It's going to change our cash flow, but that's where the drug companies are really pushing us, is to make it a little bit harder for us to capture those significant discounts that we get through 340B. That's going to primarily impact our infusion business, but it's a meaningful element of compensation. Also, CMS is pushing site neutral payments. And so the first kind of swing at that is in the infusion center. We will start being paid at Tanner for our hospital-based infusion center the same rates that physician practices will be paid for the administration of the drugs that we infuse. That represents a few $1,000,000 a year in reduced reimbursement, and CMS continues to push on site neutrality, on imaging, which could dramatically impact heart and vascular services. And then there's a number of other kind of big challenges that we're facing from an economic perspective. The commercial payers are also under a lot of pressure. I think you see a lot of press about, commercial payers are, trying to find ways to reduce their expenses, which we are their expense. And that's going to make it harder for us to continue to be financially successful in the future if we don't kind of strategically position ourselves to live in that environment. So I wanted to kind of highlight our mission, vision, values. This kind of serves as our strategic platform for how we think about the future. And we've launched into this initiative kind of plotting the Vision 2030. And one of the exercises I went through with our leadership team was asking them, I gave them a pop quiz, who can tell me what our mission, vision, values are? And I didn't get a lot of responses. Actually, I don't think anyone had this memorized by heart. I personally didn't. It's a lot of words on the screen. When I asked about the timeline that this had been developed, I heard that it's been in place for at least 20 years. I don't really know. It's been here a long time. But it's a good opportunity as we're launching into a strategic plan to redefine kind of what our strategic priorities are, how we're going to position the organization, that we take the opportunity to update this and to have it be a platform that our team feels very strongly and committed to. And so we're going to work through some projects on that. I want to talk a little bit about how we align strategy and operations, and a big part of that is our service line councils. And what I have laid out here is not a hierarchical chart of how decisions are made. It's really bidirectional. So things flow from the bottom to the top, from the top to the bottom. Ultimately, ultimately, Tanner Health Board is responsible for our strategic plan, and they'll be approving that in the next calendar year. We have a strategic plan steering committee, which is made up of the CEO and our EVP team. We have pillar leaders. So all the goals that Eric talked through, there's pillars and there's leaders and participation in each of those that provide guidance and support for the strategic goals that we set as an organization. And then there's service line councils. And the service line councils are really where we're expecting our physicians to engage in helping us set the strategic direction for the organization. I think Corinne, after this, is going to be talking through a lot of the strategic priorities for the heart and vascular service line specifically. We also expect there to be a forum and venues for physician participation kind of across the system. I'm in every single one of our practices on a quarterly basis in our communities, our TMG stakeholder meetings. We're also looking for ways to engage with independent community physicians. They're incredibly important to the success of Tanner. Excuse me. And then the kind of core underlying foundation is all of our operational and functional support. So we've got to have the teams in place to actually execute our strategies, provide input on what's working, and provide guidance to the organization on how to navigate some of those big projects. So we, a few months ago, put out a RFP for the strategic plan. We had 5 respondents, very reputable consulting firms. We narrowed that down to Oliver Wyman, who was engaged in late August, and Oliver Wyman's a large strategy consulting firm. I had worked with them previously in my prior role, and I think we're in week 9 right now, but they've hit the ground running, really trying to develop a baseline understanding of Tanner, our market, what our challenges are, what our strengths are, to kind of manage the. I need to get a drink. To manage the budget for the initiative, we decided to split off our strategic planning for mission, vision, values. So managing that internally. We're still working through some elements of how we'll roll that out to our team, but we have a workshop with the directors scheduled for January 14th, and then we're working on how we'll engage a variety of other stakeholders in that. So both physicians, community leaders, other key stakeholders within that process for developing the mission, vision, values. So right now we're in this phase 1, developing our strengths, weaknesses, opportunities, threats document, which is in draft. Establishing our baseline profile, financial profile, because a lot of this is really driven based on our economics, where we are today, with the expectation that all of those headwinds I talked about are going to impact us, reduce our margin. We've already started to see some softness in this first quarter. And so how do we prepare the organization to be successful into 2030? In phase 2, we'll actually have the strategic plan, which will layer in kind of baseline financials. And then what are the key strategic initiatives from service line councils, from across the organization, both from a growth perspective and then also a cost savings perspective, that are going to keep us successful and sustainable as an independent community health system, which is really important to all of our key stakeholders. And then we're planning to take the strategic plan to the board in late March, and then roll that out to the organization next summer. So we'll have a very detailed kind of activation plan on how we launch, what the strategic initiatives are, and how those will be cascaded through the organization. I want to talk a little bit about the framework that we're looking at. So these are the key puzzle pieces that define how we're thinking about strategy. So customer or patient selection, what the value proposition is of Tanner, how we differentiate ourselves in the market, how we capture value. So what's the, both the clinical value that we can provide to our patients, but then how do we capture that economic value to keep Tanner successful and sustainable? What's the scope of services that we pursue? So what activities and investments do we make in the scope of services we're going to provide? And we've done a lot of this work in heart and vascular over the last few years with the launch of the cardiac surgery program, advancements in what we're doing with vascular surgery, the structural heart program. So a lot of key investments there. And then we want your input, which Corinne will talk a little bit about. And then strategic control. How do we use our geography and the position that we're in to continue to be successful and independent? I think all of you know we're starting to see some encroachment in our market. We've got Wellstar coming in from the north, and then Piedmont coming from the east, and that's going to continue. These health systems, just like us, have a desire to continue to grow. And we've got to continue to grow in order to be successful and to continue to fight those challenges with our margin, and that Eric had also mentioned. So I'm not going to go through all these questions, but these are some of the high-level kind of questions that we're asking ourselves. Sorry. As we walk through each of those key kind of puzzle pieces for the strategic plan. And then kind of to finalize this, and this was my last slide, so I'll stop talking after this. We are in the process of developing our baseline financial picture, but when you layer in all the pressures and the threats that we're looking at, it's tens of millions of dollars that we have at risk based on some of these new either governmental headwinds, competitive threats, CMS changes. And so looking at a baseline margin, and this is illustrative, it's not what we're actually projecting right now, but you would start with like what our baseline is and then layer in all the initiatives. So what are the key service line projects that we're going to layer into our baseline financial picture? What are the cost cutting initiatives that we can pursue to get us back to a 3 or 4% margin, which is our goal. And that's really what we need to stay at in order to be successful and sustainable long term. So that was a lot of me talking. Any questions or comments or thoughts or things that we should be thinking about differently as we approach this?
That's great. Also, just to think about the service line for heart and vascular, you think about how we've evolved over the last few years and where we're headed and our, in terms of the whole gamut of things that we are able to offer now and eventually hopefully more. And I think this kind of almost becoming a regional center of excellence or regional center that offers all these things gives us an edge over all the competitors in the area and not necessarily their main hospital systems, but certainly over our neighboring hospitals. And any strategy to kind of come up as a regional center and advertise ourselves as a regional center to all our surrounding area, essentially increase our catchment area.
Yes, absolutely. So I think we're, evaluating what the opportunities are from a geography perspective, but also realizing that, the value proposition that we have to provide when we're reaching outside of our kind of core geography has to be a little different to attract that patient population. And so, really interested. I don't have all the answers to that and how best we do it, but really interested in exploring it further. And if there are ideas about things that we can do to kind of expand geographic reach, I'm very interested in working with you all to support that. Thank you.
Thank you so much, Clint, and thank you, Eric. We are so fortunate as an organization to have such strong operational and strategic leaders. I've been in a lot of places, and I can tell you, this is a great organization to work for and such great teamwork between these two. So I hope you enjoyed those presentations. So we're coming up on the holidays, right? And whenever I think of the holidays, I always think of those people that are the glue. Right? I think all of us have them in our family or maybe in our work environment. Those people that are the glue, right? Holidays are busy. There's so much activity. Sometimes there's budgeting involved. There's so much going on. But we all have those people in our lives that are the glue. Now, service line work to me is the glue. So we got a great presentation from Eric on some of those things that are the operational needs, those pillars, those metrics. And we got a presentation from Clint on, okay, what's next strategically and how we're going to be very methodical in that. You all, this group, and we're still a very young service line. This is only our third meeting. But to see the talent and the expertise in the room is so exciting to see that this is the glue. We're the glue to help answer those questions like you said, Dr. Kawaja. What's next? How do we elevate ourselves? How do we make sure that we're attracting patients from outside the area, continuing to grow and invest? The growth in EP, bring on intentional navigation and heart failure, all the work in structural heart. You all are pulling together those operational and strategic needs to really elevate the organization. So I'm going to take a few minutes and I'm going to walk us through how we as a service line align with our operational goals and then to get us thinking just a little bit about those strategic questions. Sound good? Okay. So service line focus. When you think of a service line, there are 5 main areas of a service line. And we've talked about this a little bit before, but just a reminder. First is alignment, right? Alignment between operations and strategy, between clinical expertise and operations, all those areas, ambulatory hospital, alignment. And if you look around the room, that's what this group does, right? Next, advancing quality and service. We have great teams that work on this on the hospital side, on the ambulatory side, but the service line, it was what pulls those pieces together. Monitoring financial and operational performance. So we need to be aware of what's important for the organization, be able to understand how we're contributing that, and then also, as Clint was saying, that bi-directional communication. And then finally, leading a strategic growth. So where do we need to grow? What are our opportunities? What should we lean into? So as a service line at the beginning of the fiscal year, which was just this summer, we picked a couple, now this isn't everything, right? Just a couple high-level goals that align with each one of our pillars. And what you'll see is that the operational metrics and the service line metrics complement each other, right? They're not in competition, they're complementary. And so these were, as a first time kind of new service line, what we identified as some areas to lean into in alignment with each one of the organizational pillars. And so we've either completed or are on track for each one of these. So real quick, people, we said, hey, we're going to keep going with the service line thing, right? And I think we're getting great participation. Thank you again, all of you, for being here. I know you're all extremely busy and have lots to do, but you chose to be here this morning and continue to lean into this. So thank you. Next is navigation. So we have Adrienne. We're so excited. She's already making an impact on our readmission rates, which we'll talk about. But so excited, complete, right? Check mark. Here we go. Next, education. This is part of service, which we measure through our Prescadian and other areas. So really working on that education piece. This is something, again, that Adrienne is helping us with, as long as our preventative cardiology committee. Efficiency, we know access is a huge pain point for us. So we're so excited that we're bringing on more APPs and more talent joining us next year. Finance, so this is that piece that you mentioned, Dr. Kawaja. We want to be able to be advanced enough to look at cost per case, to find opportunity for us as a service line to say we can do better, we can find savings. How can we contribute to the organization and what their goals are? So that's something we're working on with finance. And then growth, EP. My goodness, I don't know if we could grow any faster than we are right now in EP, Dr. Okamali. You've got us hopping up there. I know Laquita and Brandon would say the same thing. So just blowing out of the water any projections we had on growth with EP. So does this make sense, right? So we're aligning with the pillar goals. They're not the same, different measures kind of, but we're fitting within those goals. And then something else, that we worked on this year is launching all of these subcommittees. So we can do work here as a big team, but also the real work happens within these subcommittees. And so all of you have been so engaged in having these conversations with those multidisciplinary teams with lots of people that are not in this room to make sure we're pulling them in and aligning them to the same work, right? So you'll find your subcommittee report out in front of you. And so each subcommittee picked at least one goal for the year, right? And so you'll see an update there, and we'll have a little bit of time to talk about that later. But this was kind of what we said, brand new service line. This is how we're going to align. This is how we're going to organize ourselves and what we've been working towards this year. Now, if we go back to those 5 areas, right? There's lots of work happening in these 5 areas outside of those big buckets of goals that we mentioned and the subcommittee work. So what we did is we put together, and I'm going to pass this around. I'll start half of it on this side and half of it on this side. We started, and this came out with the minutes and the notes ahead of time as well. But we pulled together with Miles and Laquita and Marcy and others. We just said, what are all the things that we've been working on as a service line? What are kind of things that are currently in the works or that we know are on the horizon? What does that look like? So what you're getting right now is a list of initiatives that's broken again down into those buckets of work per service line. And what we'd ask you to do is to review that and to say, what are we missing? What do we need to add? And this is right now what we're giving to the consultants to say, this is kind of current state work that we're looking at for the service line. So I'll give you a minute to look at that and then ask any questions. But ideally, this would be an ongoing conversation, right? And as Flint leads us through this strategic work, he'll be able to come back and also share with us where we're going as an organization and some of the things that the consultants are finding. Just front and back. There's probably more things we could put on this list, which is part of the reason that we wanted you all to have some time to review it, is if there are more things that we left out.
Can I just add?
Absolutely.
I think when I look across all of the initiatives we're working on as an organization, it can get a little bit overwhelming. And part of what I'm hoping through our strategic planning process, that we can identify what we're going to focus on as an organization, but also most importantly, or sometimes more importantly, what we're not going to focus on. And I think having that kind of crystallized vision around where you point your resources most intently is how you execute on these initiatives and get them across the finish line more quickly. Doesn't mean that we would, if we, push something down the priority list, doesn't mean that we would never work on it, but it frees the team up to be able to be intentional about how they execute on specific initiatives. It also allows us to, as an organization, meter and kind of monitor our capital expenditures so that they match what's going to keep us successful and sustainable long term. So I just wanted to add that. I think it's really important to think about what you're going to do, but also use a framework around what you're not going to do and be thoughtful about that.
Yeah, I think that was really well said. Every yes to one thing is a no to many other things, right? And so how we lean into that and how we prioritize. This sheet is just to be kind of all encompassing all the things we've kind of talked about, but through this process, like Clint said, hopefully we'll get a little bit more laser focused on what's top priority and then how we execute. I heard a healthcare executive once say, almost every healthcare organization, their strategic plans look very similar. It's their speed to execution and their targeted approach, which is what Clint's bringing, that's going to make us really have an advantage. Any questions? Is this helpful? You can feel free to send any edits or suggestions to me. I'm sure you can reach out directly to Clint or Miles as they walk through this process. But we hope that this kind of brings this team into the process and this journey that we're embarking on as Tanner. Any comments? Okay.
I'm just glad no one mentioned they wanted to do transplants.
I'm going to turn it over to Dr. Aaron and Joseph to talk to us a little bit about structural heart for our clinical spotlight. Oh, sorry. There's a question. You had a question? Yeah. Yes.
As we increase our thoracic volume,
Yes.
would it be value engaging more with the pulmonologist to see what are the barriers for referrals of patients here? From what I understand, we're waiting for the navigational bronchoscopy equipment, and Dr. Reed has done the training, so he's eager to start. So
Yes.
would like to get
Sure.
them more engaged, and hopefully that will increase their referrals.
Yes. Now that's a great call out. And I know there's a lot of activity happening right now around lung navigation and cancer. Amber, anything you want to add about the project and what you guys have been working on from the invasive? Sorry, go ahead. Not to put you on the spot, but I put you on the spot.
Yeah, so we have gotten all of our quotes for that equipment. It's all been submitted to the capital committee. So just waiting on approval for that. There was a little bit of work in the room that needed to occur just to support that equipment once it arrives. All of that has been complete. So once we get approval for that equipment, we will begin the training process for our staff members. Really, I think we're just, kind of waiting on that approval and we'll be ready to roll.
Great. And I think that's a great example of where we can do something similar to what we've done with the other subcommittees and get all the stakeholders in the room and talk about programmatically what that could look like. So, thank you. Okay, Dr. Aaron.
Everyone. I think that, this is, I'm going to click this video to start with this. This was actually the first TAVR that was done here. And it took that long to deploy. However, everyone in this team, in this room, has been on this team and been on this voyage to get to this point. I mean, I can't, if I sat here, I would be here all morning thanking everyone in here for the incredible collaborative effort to get us to this point. And that includes, all of, general cardiology, Dr. Green, Dr. Quadja, the CT surgical team, CT anesthesia, the cath lab staff, the OR staff. I mean, I hate to even start calling out people because I'll forget people's name, because everybody had a huge stake in getting us to that point to deploy that valve. And I must say, to me, it's probably been one of the most exciting things for a lot of reasons. One is when Dr. Quadja did his amazing talk on TAVRs recently, I mean, it really did. You kind of see the first time I feel like that you got the cardiology team and the CT surgical team that are truly sitting in the same room, doing the same thing with the same goal. And it's incredible to work with the friends and colleagues in this room, but it's amazing to actually work in the cath lab and doing procedures like this. And this is just the tip of the iceberg. I'll tell you, I've been doing this for 18 years, and there's probably not one thing that excites me more than where a structural heart is going, and also the continued collaboration with our CT surgical colleagues. So I'll start with that and just say it's incredible, and thank you. But just a brief current state, we've done 12 procedures, 17 projection in this year, 39 in year 2. I will say we're doing cases, and we really haven't even launched the initiative to get this word out there that we're doing this yet. So this is just the tip of the iceberg. We're looking, so far all of our cases have been general. Our first MAC case will be this coming up Tuesday, if everything goes according to plan. This was just not necessarily about the TAVR, but really this was another huge collaborative effort, was to get our ICU up on CPCU as well, so that we can have a high-risk patients up there and recover them on CPCU. We've done 12 patients, mean age is 75. Half and half male, female, STS up there at 3.75. All have been sapient, all have been transfemoral. We're having good follow-up with our patients. I think that's one of the nice things about our system, is that we do have a close connection with our patients. They usually don't get lost to follow-up. We're able to see them and keep that ongoing. As of right now, I love this. 100% procedural success and really no major complications. And that's incredible. I'd like to think it would stay that way. We all know it's because everyone in this room does these procedures, and we all do high-risk things. That will probably change, of course, but it sure does look good right now. These are just some of the marketing campaigns that we've done from a program standpoint. Now we're starting to get the word out. Really feel like this is going to ramp up even more. And then, as Dr. Quadja alluded to, we've already done 6 Watchman devices. This is going to be a beast, to say the least. Right now, Watchman devices are just in patients who can't take anticoagulation. In the future, the studies will show that it's probably, if it ends up being what we think it is, it's going to be an alternative to anticoagulation, and it's going to be a patient preference. And when that happens, we'll have a Watchman panacea. So, like I said, this is just the tip of the iceberg. It's been nice, heart team approach. I think a lot of people, but I do want to send a special thanks to Joseph. Joseph, you've done an incredible job with helping us navigate this uncharted territory. And I just want to say thank you. You've been incredible, at organizing a bunch of people. It was hard to organize, and I get that, but also patience as well. And I just want to say thank you for everything you're doing, and for everyone in this room. It's been an incredible journey so far, man. I'm looking excited about the next steps. I'm willing to answer any questions if you guys have anything, or if Joseph, if you want to say anything, feel free.
Yeah. Thank you. Okay, man, I appreciate that.
Hey, can I just ask a quick question?
Certainly.
What's the expectation for starting PFOs and here? Is
Yes.
that coming this year or next year?
Yeah, we're listen. So no, absolutely. So we're already, I'll put it simply, we're already poking holes in septums. So we're really excited. We're really excited to start closing them, and that'll be a natural step. That's I would say at this point, our first PFO ASDs, there's no reason why we shouldn't be able to close those. Like I said, we are putting holes in them now. And then tier, also, everything is kind of with structural as a progression, right? To do a transcatheter edge-to-edge repair of the mitral valves or even percutaneous mitral valves, you got to have a transeptal approach. So we're laying the groundwork for that. That certainly will be, in the future. I don't know exact start date for that, but man, we're eyeing that as well. The PFOs and ASDs, I would say, as soon as we start having patients who need those closed, there's no reason why we can't absorb those here at Tanner.
Yes, sir.
Did I answer your question?
Yes, sir.
One of the things we love is the reach out to physicians and providers and other public for TAVR. And I think we'll probably talk about that in our marketing campaign over the next few weeks, months, to how to reach out. And that would obviously increase for work for general cardiologists as these patients come in and now they recognize their symptoms and coming in. But, obviously that's coming down the road as well.
No, absolutely. And like I said, it really is. We're working, having the ability to do this in conjunction with world-class surgeons like Dr. Latouf and Dr. Dafton. It's I don't know. This is incredible. And I feel like, we also, we've got so many different ways that we're going to be capturing these patients. And so navigating that is going to be exciting, especially physicians, they'll be referring everywhere. So having this cohesive team is going to be incredible.
Yeah, I guess we could do that.
So with the time left, we have some time if we want to look through the subcommittee report outs, if there are any questions or anyone would like to share anything, or just general questions. I'll do the microphone running. Get my steps in this morning.
It is very clear that we have the key ingredients for success with outstanding administration that partners with outstanding clinicians in cardiovascular. When I came here, I only had to follow the footsteps of Dr. Kawaja and Dr. Arendt and to keep the high standards that they have established. And our program was successful. So you already have a standard of excellence that is the envy of every institution in the state. To continue to grow, in addition to the excellence that we have administratively and clinically, I think there are two fronts that we must focus on. One is how to maintain patient loyalty in cardiovascular, and what can we do to maintain that patient loyalty? What services can we offer? What programs can we materialize that no one else does, where patients and their families, that they could have lifelong loyalty to that? And the second, in order for us to be successful, we must have loyalty for our staff, particularly our nursing and admin and other clinical associates. How do we maintain that loyalty? And as we grow, how do we bring more to Tanner so that we can have continuous inflow of very bright, active, and energetic people? I think those two elements, if we figure how we can strategize for them, we can withstand the onslaught from very effective and very capable competition from Piedmont and Wellstar. Those two organizations are guerrilla organizations. They're exceptionally capable. With the resources they have and the funds they have, theoretically, they could overrun any small organization. But how can we protect our environment and grow that? I have some ideas, but I'll leave it for you to think about it.
Dr. That's so well said. Thank you for the kind word. This has been obviously a team effort, but I really think your words are right on. How do we? And I've always said that. And if patients don't get good care, Atlanta is only an hour away. But if they get good care, Atlanta is an hour away. And it's really true that if you don't offer good care and quality care, then it's very easy to go to another system. And I think and all of these things, pillars and everything's all great, but it's at the end of the day, it all boils down to it's patient-centric care. And it's really, truly at the end of the day, if your patient's not at the center of the care, then nothing else really matters. And I think if we can't genuinely do anything to make our patients' outcomes and life better, then really none of that matters. And so I think our goal, and I think I was just going to talk about that in closing remark, but just this is a great lead way into that, is to how do we transition into that and just make sure that all the things that we do are so quality based and so guideline based and so much in uniformity with each other. And how do we track that? How do we really truly penetrate into everybody and educate and try to keep up? And there's so many other ideas, and certainly we'll expand as we come back next time. But I think it's at the end of the day, it's patient-centric care. If the patient's not happy, you can offer them the latest technology and they won't be happy. If you can't spend 2 minutes with them and talk to them and educate them and care about them, and I think all of this would not. So I think Tanner has a great focus on that. And I think that the physicians, the providers, the nurses, the team, the administrator, everybody is really truly patient-centric. And that's the unique thing about this organization, that I can say that genuinely for the last 18, 20 years that I've been here, that it's always been about patient and what can we do to get better outcomes, regardless of the cost of the care. And even though we have to be sensitive about that, but I think at the end, it really has a huge impact on our patients' lives. So I think as our goal as we move forward and is to how do we bring more and more objective education, more objective ways of educating our physicians, providers, staff, nurses. And you already do that. You already have a great series of cardiothoracic, and I think we have other plans to start and initiate. And how do we engage the medical staff into that, so we truly become truly becomes part of it. The other part is research. As we get busier into this, how do we incorporate that? That elevates the level of our organization, our service line, and certainly having medical students and others to teach and bringing fellows and eventually, because that would help. Once you start educating, you really learn a lot from them. So, but hopefully that's the direction we'll go. So thank you. While I'm here, I kind of have a mic. I'll just talk a little bit about the interventional part. So just the things that Corinne talked about and things that what we're doing. One of the things we looked at was our mortality review, and we found that there may be opportunity in coding things and things that are not expressed in our notes and that the patients have, and that truly it's a mortality index essentially based on what other risk factors or comorbid conditions they have. So great help, obviously. Thank you. And I think that's reflected just in the first quarter now that our mortality is all of a sudden changed. And it's not that we're doing anything different than what we did before, but it's really, it translates into how that's looked at. So and that's how we project it, and that's how people look at that, unfortunately, fortunately. But again, important to pay attention to that. So we did, and that's already showing. I'll pass on to others, Dr. Adley, Dr. Okamali. Dr. Adley, you want to say something about heart failure?
Yes, Adrian. We have in the heart failure clinic great response with the advent of pharmacists being there and helping to educate the patients about their medications and try and help them get the medications that they need, despite the lack of affordability. The initiation of Adrian has been just fantastic, improving our referrals and appointments made from discharge to the appointments. I can't say enough about how instrumental she's been. I'm just going to hand Michael.
Okay, thank you. So aligning the patient education was one of our big goals. So we have our booklet and our flyer, and every patient that I see gets that, whether they're going to Dr. Adley's clinic or if they're going to Dr. Rouse's, and I just tell them to call you versus Tanner Heart and Vascular. I want to make sure they are getting the same education. And if they don't understand that, I'm going to call family and make sure they can get on board with it too. So once they do go back home, they're actually going to be taken care of, whether they can take care of themselves or not. And then just following up with those patients and making sure they actually do understand write down your questions. I'm going to come back. So I think that's been a really good improvement. And then coming to see y'all too and seeing those patients over there if I miss them in the hospital. So that's made a big difference, I think.
Yeah, I'd like to jump in just real quick. So, yes, the two of you have been fantastic. And Adrian, you've been an unbelievable addition to our team. And I'm normally pretty loud. If you look at our star ratings, right? So we've been talking a little bit about the encroachment of Wellstar to the north, Piedmont to the east. So what people do is they use this publicly reported data for marketing, for their strategic initiatives, for how they recruit patients, and patients are looking at it. You talk to my folks, my dad lives on, CMS.gov, hospital compare, and he's just looking to see, but that drives a lot, even if it has nothing to do with a particular thing they're getting done. They're like, well, this hospital is really good, so I'm going there. The two things that drive those star ratings more than anything else are going to be CHF mortality and CHF readmissions. So that readmission mortality piece is 50% of the total grade. So that puts things in like efficiency. It puts things in like patient experience, Medicare cost per beneficiary. But the two things that drive it the most that are going to turn it one way or the other are going to be CHF. And because of you in the last quarter, we've had a statistically significant decrease in the number of readmissions that are coming back into this hospital thanks to the two.
Just as we move forward and have Dr. O'Malley, but also vascular surgery and under the leadership of Dr. Park, done amazing things and really a major growth and also just ongoing help to patients for all these years. So I just want to recognize Dr. Park and vascular surgery and if Dr. Park has anything to add.
I don't have anything specific to add. I think noted on our sheet here is a little challenge for us coming up. Our hybrid OR is going to be revamped. So we're going to be looking for spaces to do cases, and Amber's helping us with that. And I know everybody in the cath lab's kind of participating, and we've been nomads, but we'll continue. And we're recruiting for a fourth, obviously have been for quite some time. Have some interest from a woman coming out of training in Florida. So fingers crossed for that to see her join us next summer.
You want to say something about T-cars? How many?
I don't have numbers for T-cars. Transcarotid stent, open carotid stent placement has a little better stroke profile than transfemoral carotid stenting, similar to open carotid endarterectomy, but a little easier recovery for high-risk patients. So the three of us have done a fair number of T-cars. Still for us, kind of a two-surgeon case, everybody on board, but the patients that we've done so far have done well. So we'll continue to expand that. And I think we're all kind of looking at that as somewhat equivalent to carotid endarterectomy at this point.
Great, thank you.
Thank you. I think from an EP standpoint, I think we've seen, as was discussed earlier, a growth in our ablation program. I think it's one of the things that has picked up. Still working through the kinks in terms of early referral, because I was just looking at the numbers. It looks like we tend to do more about, say, 60-70% persistent AFib and 30% paroxysmal AFib, where, as we do know, recent data showing that the earlier patients who are diagnosed with AFib within a year who get early ablation have the best outcome. So we've been working on that, trying to get early referral for patients, both with device-detected atrial fibrillation, but in general, we've been doing well. In the lab also, we've worked very hard on our turnaround time, and now we're now able, at least for an AFib standpoint, to schedule and perform 3 AFib ablation a day, which is a huge improvement in terms of our time. So we think definitely as we go forward, that's really going to improve. Also, we had implanted our first sub-Q ICD here, which and I spoke with, in collaboration with anesthesia, have been very supportive in terms of doing thoracic blocks and some modern technique we use in order to control pains for patients who undergo sub-Q ICD. So we continue, hopefully in the future, we'll continue to see growth in this in terms. We're also planning to get an additional, hopefully, an APP to help out in the EP clinic for the next year. So far so good. It's been a tremendous growth in EP, and anticipate we'll continue to see that going into the next year.
I think just while you were talking, I think, I don't know if there's an interest eventually in convergence procedures with CT surgery and,
Yes.
you know, and obviously.
Yes, that's a lot. Working still on the collaboration for patients with, especially since I'm seeing a lot more persistent AFib, to collaborate and to form more almost like an AFib center of excellence where we work more with the cardiothoracic team, rule out sleep screen for sleep apnea and things like that to make sure that we give a holistic care for patients. Because one of the big indicators also for heart failure is new onset arrhythmia, of which we see a lot of patients with devices who have AFib. And then if it's not addressed earlier enough, at some point they end up in the ER with congestive heart failure.
You know, just to, and we'll take it behind the scenes with Miles, Pat, and you can just maybe talk about just a direct AFib referral or service line part that those patients could be directed from primary care and others. We'll talk behind the scenes on that, maybe to talk about how that could be created. Dr. Green, excellent.
Hi, good morning. It's been a bit fairly busy quarter with cardiac imaging. You know, Marcy takes care of a lot of things behind the scenes. You know, since the last quarter, we actually got the probably the key points is that we got the accreditation for the nuclear medicine and PET. So we've had you know, it's been very rewarding to see that to come to light, and hopefully we'll be getting the ECHO accreditation as well in the future. Also, you know, the collaboration with doing the Watchman with the interventional team and cardiac anesthesia and nursing, the whole cath lab staff, that's been quite rewarding. I know kind of echo a lot of the same sentiments of Dr. Arant in terms of being in the cath lab again, and this time more on the imaging perspective. You know, we're working on the nuclear cameras. You know, there's some upgrades in process that we're going to be working on. So, but of course, we get, you know, looking at the numbers and so forth. And then probably lastly, you know, I was able to spend some time with the a new software called Cetra in terms of the imaging. We use Philips now, and I really see this being the future in terms of cardiovascular imaging. And there's some AI models in there as well, not taking over our jobs as cardiologists, obviously reading, but kind of just enhancing it. So I think that's going to be the future. And talking with administration, there's definitely a need to have a better turnaround time in terms of, you know, reporting echoes, nukes, and so forth. So I think better software can definitely, you know, guide us into the future, 2030 and so forth. But it's been exciting times there. So.
I just want to say Dr. Green's been so instrumental in all these programs with towers or with the Watchmen and so many other things in imaging and always, you know, amazing to have this expertise. So thank you. But Dr. Rouse and Dr. Latif.
In follow-up to the rightful compliment paid to Dr. Adley and to Ms. North for reducing congestive heart failure readmission, I want to pay compliment to our outpatient team, Kristen Carmen and Ms. Crawford and Miles, for although we have a very low mortality rate as inpatient, and other institutions have an outpatient mortality rate in the first 30 days of about 20%. Our 30-day outpatient mortality rate has been 0. And that is a no small feat. And that is because of the incredible follow-up that our team does. They call patients, bring them back in the first week. Any issue of concern, they will alert us and we will address that immediately.
Jan.
And so I want to compliment you for that. Thank you,
sir. Thank you. Thanks, Beth. Dr. Rouse.
Yeah.
I think Dr.
I think he needs a CT surgery consult because he's got.
Dr. Rouse, you can go ahead.
What a great way to end. See, they're listening. They're listening.
Right. So many of you know over the last 25 years or so, we've been doing a lot of screenings in churches and civic organizations, et cetera, around the Carroll County area. What we've noticed, we've screened about 100,000 folks. And what we've noticed is about 30 to 50% of them have high blood pressure, diabetes, and other kinds of risk factors that's driving this mortality and incidence of cardiovascular disease in the rural community, which is higher than it is in the rest of the state, in metropolitan areas. So one of the biggest drivers we see is this incidence of obesity in the rural area in terms of these cardiovascular markers. We have secured a 37.5-foot van that is equipped with 2 exam rooms. And one of the major drivers behind, probably mortality and incidence of diabetes and high blood pressure and all those kinds of things is a lack of access and uninsured folks. And so we've identified where these folks are in our rural communities. There's Tent City, which is a place where individuals who don't have a house live. There's unhoused and extended stay facilities, et cetera. But anyway, these places are around in the community, and we have this 37.5-foot van that we're providing free services for those individuals in collaboration with some efforts with Corinne and the Tanner team to provide free services and access to healthcare. We'll provide services in terms of basic needs, bronchitis, earache, et cetera, but everybody that's 18 and older gets a free glucose, free cholesterol, free blood pressure, BMI assessment, and an EKG in an effort to try to detect some of this early cardiovascular issues. So that's where we are. And I think Dr. Khan is on the line.
That's amazing. Thanks for what you do for the community.
Dr. Khan.
Dr. Khan, are you on?
Yeah, I'm here. I'm just gonna kind of, say what Dr. Rouse mentioned. I think we are making huge progress, and Dr. Rouse, I think he does a lot of outreach and community work, and we've had, one thing I was thinking about was social media approach, and like that's one of the hospitalists who kind of talked about, he attended an event by Dr. Ralph for the outreach, and I was thinking maybe we can have more social media presence, not just Facebook, but I know we have it on there, but there should be other ways because a lot of, I guess, I want to say younger generation, like middle age and onwards, people are also using our other social media, and kind of having a big presence there is going to be helpful in kind of reaching out and to the community and making them aware of all these events that are being done by Tanner or by Dr. Ralph.
Thank you, Dr. Khan. Dr. Dent.
Just to follow Dr. Akumali's presentation, since I came here, we started doing a lot of vein isolations. Every patient that we operate, if they have similar population, we isolate them. And we remove the left atrial appendage, which decreases the chance of stroke by at least 90%. So additional thing that is available for your patients.
That's great. Yeah.
And if they are appropriate candidates, we can do full MACE procedures in addition to coronary bypass or aortic valve placement or mitral procedures. We are able to do that.
That's great. Well, thank you. All right, I think we'll probably stop. We're past time, but just closing remarks. I think we all talked about things. We'll have a happy New Year. I guess the next time we see would be 2026. And I don't have anything else other than what we talked about. Thank you, everybody. Thank you.
Please make sure you fill out your disclosure form and leave it with the med staff team. Thanks, everyone.
I saw that patient of yours. Yeah, I think these is done. I think oncology doesn't think it's gonna do. I think we should just, they're saying diabetes, exactly. They said diabetes, so it's just private information. It was without oxygen to make it drug. Okay, I think oncology.
There's one on the other side.
About